Good evening for everybody, and welcome to the 6th episode of Glaucomatology 2020. This episode will deal with glaucoma in the child. We all, as glaucoma specialists, deal with many kinds of glaucoma, and probably one of the most types of glaucoma that needs very special attention and special care is glaucoma in the child. For the child and for the region we live in, because we know that we have one or the highest incidence in the world in the Middle East of congenital glaucoma and developmental glaucomas. We know that it is not there much in Europe, it is not there in many other parts of the world. If we see 100 cases a year in one place, in one hospital or more, other countries, a whole country might see 100 cases over 100 years. So this is a fact we should acknowledge. So we have developed some experiences in this field, and we would like to highlight in this webinar that glaucoma in the child needs very special attention in the examination and the care and the surgery and the post-operative management and in the lifelong follow-up. So anybody can learn, but everybody has to learn well before encroaching on the treatment of this glaucoma. Because as we are going to see today, if we just start our treatment by giving the medical treatment we give in the adults, we will happen to give alpha agonist eye drops, which can kill a child. And if we go on other surgeries, which are commonly performed in the adults, we will eventually end in failure. We all know that. So anybody can work on congenital glaucoma, provided that this body learns as much as possible. And we have many centers of excellence all over Egypt and in the Middle East, which teaches the fine art of treating glaucoma in the child. Today, this is the layout of our course today. We are going to try to make it a seamless course. So we are going to talk about classification of these pediatric glaucomas by Professor Nader, the diagnosis, the differential diagnosis, and then we talk in this section in the middle part about the treatment, whether it is medical treatment or surgical treatment, and then at the end we will talk about two specific types in this young age group glaucoma, which is the aphakic glaucoma, and then this is the missed glaucoma, which we missed in our last episode, by the way. We hope we do not miss this evening. So we start by our classification, and we will move from one speaker to the other as the course goes on. Dr. Nader B.
Thank you very much, sir, for this excellent introduction. So now, good evening, everybody. This is Nader Bayoumi, and this is the first part of my presentation, which will be the classification of childhood glaucoma. We'll highlight first the titles, and then we'll go a little bit into details. Now, childhood glaucoma is recently classified into primary or isolated childhood glaucoma and secondary to systemic and ocular diseases and conditions. The primary or the isolated is further classified into primary congenital and the juvenile open-angle glaucoma, whereas the secondary may be associated with non-acquired ocular anomalies, be these ocular or systemic, or associated with acquired ocular anomalies, or a specific entity known as glaucoma after congenital cataract surgery. So, just a very brief mentioning. This is not to mention the diagnosis, which we'll hear in details in a few seconds. We just mentioned the few criteria: intraocular pressure above the statistical normal of 21 millimeters mercury, optic nerve cupping, corneal manifestations of childhood glaucoma, myopic shift or increased axial length, and visual field defects. If any of these more than two of these exist, then we will shift to the diagnosis of childhood glaucoma. If these are not present, then this classifies the child as a glaucoma suspect. So, what if any of these conditions are met, and they are met only after surgery for a cataract in a child, and the glaucoma was not present before the cataract surgery? We classify this as glaucoma following congenital cataract surgery, regardless of the type of cataract, whether idiopathic or congenital cataract associated with ocular or systemic anomalies, or even an acquired cataract. If these criteria are not related to cataract surgery, then the second question, are there any congenital anomalies in the eye or systemic syndromes? If there is a systemic syndrome, then this classifies the glaucoma as glaucoma associated with non-acquired systemic disease or syndrome. And if there is no systemic involvement, then this is a glaucoma associated with non-acquired ocular anomaly. So it's either a systemic or an ocular anomaly. If there are no congenital anomalies, we check if there is any history of any condition that is known to result in glaucoma, whether trauma, uveitis, steroid use, tumors, retinopathy, prematurity, etc. If any of these exists, then this would classify the glaucoma as that associated with acquired ocular conditions. And each of these, of course, is classified gonioscopically into open angle or closed angle. If again, there is no history of any condition that is known to cause glaucoma, is there a large eye or a buff thalamus? If it is present, then this classifies the eye as a primary congenital glaucoma. According to the onset, may be neonatal, infantile, or late onset, and if none of these is present, then this classifies the eye as a juvenile open-angle glaucoma. So this will put an end to the classification, and I'm done. Dr. Ahmad, please take the lead. We would now be delighted to hear the diagnosis and the evaluation of primary congenital glaucoma by Professor Ahmad Khalil. Please, sir.
Thank you very much. Evaluation of the early onset developmental glaucoma, primary congenital glaucoma, as we mentioned, warrants special attention. It has to be properly diagnosed, and it has to be continuously followed up through life. So cases of primary congenital glaucoma can present, as we all know, by corneal cloudiness, large corneas, tearful eyes, and intolerance to light. So probably if we start actually vice versa, although this because corneal cloudiness ensues in the severer cases, intolerance to light probably is the first sign, then tearful eyes, large corneas, and corneal cloudiness ensues. We have to evaluate the intraocular pressure. After all, this is a glaucoma, and we know that the cornea gets bigger and cloudy, so we have to examine this properly. And the optic disc is one of the mainstays of the diagnosis of glaucoma in the infant. The axial length is another way of measuring the size of the eye, together with the corneal diameter, and other tests are also there to do. Personally, in my practice, I bring the optic disc to the forefront of the examination of the glaucoma in the child or in the infant, and I'm going to say why. We start by the cornea, which is probably the usual presentation of these infants. The cloudy cornea, we know it's the commonest form of presentation in most of our centers probably. So these are various forms: the megalocornea, slightly cloudy cornea, and the very big cornea in other eyes. So the megalocornea in all these. The subtle enlargement. Sometimes the corneas are large, but not remarkable. And parents consider this is a beautiful eye. Consider this child also on the right. Do you see it as big or normal corneal diameter? But if we remove the patch from the left eye, then we realize the size. So this child was one of the unfortunate children who have visited one of the colleagues who advised against any intervention of this congenital glaucoma, and when he presented, it was totally blind, unfortunately. But the other eye was very normal, and we see the clear difference between both eyes. The photophobia and tearfulness is very common, and Professor Nader has mentioned the nasolacrimal duct obstruction, which are commonly confused in this disease and age category. We have to measure the corneal diameter, and usually this is done in the operation theater, and usually we find corneal diameters more than 10.5 is like more diagnostic, and then actually corneal diameter can change, and this we have been in debate about this for many years, but corneal diameter can regress. So the eye on the left is the corneal diameter has got smaller, and it started to show abscess striae after clarity of the edema. So we move to other parts of the cornea. You see, maybe the picture is not very good, but this is again is the examination microscope, retroillumination, and there is microepithelial edema in this eye. And this was actually the hallmark of the diagnosis in that child. And sometimes it is very faint cloudiness, like in this eye. This is one eye which had this when the eye was on medical treatment, so the edema was collected in bands like this, but after resolution of the disease and following surgery, so these are the abscess striae, the same patient with these bands from before and after surgery. The cornea can in some cases be actually the hallmark and the forefront of the diagnosis. Like this infant, actually, this was a confusing eye because this eye, we were not sure if it is shed or endothelial dystrophy or no, and because the pressure was not very high, but we chose to do an operation, and 1 week after the operation, this is the operated eye, the non-operated eye. You see there is no big difference, so we stopped and we didn't do the second operation, but in due time, you can see the clarity of the first eye or the operated eye and the still cloudiness of the left eye and following surgery, so this was clear. So in the first few weeks of life, the eye pressure does not usually get very high, so we have to pay attention that sometimes the pressure is not the hallmark of this disease. Although it is the mainstay in glaucoma in general, but here it is different. You see, when the eye pressure increases inside the eye gets bigger, so this offsets a little bit the eye pressure. And this is a very old, actually dating since the beginning of the 20th century, and now it is more and more evident that the normal intraocular pressure in the child, in the infant, is not below 21. No, it is below 14, it is below 12. So you see this is a graph in this first year of life, it was, this is the Schoid's measurements, by the way, 8.99, etc. And by the age of 5, then it is 13. So a pressure of 21 in an infant is not a normal intraocular pressure. The examination, probably I put the Perkins in one line and the other instruments on the other line. We have many newer and older instruments. Still the Schoid's can be of use and the other new modalities, but the Perkins remains the mainstay of measurement in these children. Anesthetic considerations, how do we measure? In the newborn, in the first few weeks in life, you can measure the pressure actually at your office because the child is rather helpless, and if he is little sleepy with his mom hugging him, probably you can get a glimpse and you are able to measure the intraocular pressure at your office with no anesthesia at all. And this can happen. If we are not able, then we go to the operation room. And at the operation room, we use anesthetic agents, and anesthetic agents all have an effect on the intraocular pressure, sometimes by increase and by decrease. Naturally, most of the agents, anesthetic agents, lower the eye pressure at different stages of anesthesia and depending on the anesthesia. So most commonly nowadays we use sevoflurane. Sevoflurane lowers the IOP remarkably, maybe 5 to 7 millimeters mercury, but at some stages it is actually the same as the with no anesthesia. And I have tested this with some of my patients. So you need to know the stage of the anesthesia, and best is to measure from the very beginning of the induction till the deep anesthesia and then before the child wakes up. The device considerations, each device has its own maneuvering systems. So you have best to avoid contact only, but for the cornea. So avoid contact with other, of course, hitting the eyelids, etc., and know your device well. The anatomical considerations, these are small eyes of babies, larger eyes inside a small palpebral fissures. So by any even gentle opening of the eyelids, the canthi on either side pressurize the eye and increase and give a false eye reading. So you have to be very gentle. And personally, I take several measurements and I separate from the patient at least 5 times. Total separation between me and the patient 5 times. You have to standardize your instrument. You have to take several measurements, and I take actually the lowest measurement, not because it is the most hopeful, no, but because probably it was the least that had pressure in the eye. And again, we are not happy if the pressure is 18 in a newborn. This is the examination in the operation room. And this is the examination in office. Sometimes, if you know the child from the very beginning, you can train him by a smart mother, and this child was less than 1 year old, and it is possible to measure if you know your child well and your child can trust you. Actually, this happens not infrequently. And then when the child grows up, this is maybe 2 or 3 years old and older and older. So you can have different settings. This is totally awake children in the office setting of the Research Institute of Ophthalmology. And the child is helped by the nurse, or sometimes he helps himself, like we see on the left-hand picture. So the optic disc has also a very important brunt in the diagnosis and management of the congenital glaucoma. The normal optic disc in infant has no cupping. This is a very important statement. So any disc more than 0.3, this is definitely a pathological disc. 0.1, 0.2, you can be suspicious. Optic disc cupping larger than 0.3 is pathological, is glaucoma. So dilated fundus examination, disc evaluation are very essential in the follow-up of these children. It is steep-walled, it is central, it is circumferential, oval when it is progressing or regressing. Particularities in the optic disc infant, they occur readily with changes of IOP. So the IOP increases, it increases. The IOP decreases, it decreases. Reversibility of the optic disc cupping. Early appearance of cupping, maybe mechanical distortion, and stretched out globe, and finally neuronal loss, then insus. That's why it is reversible, and that's why if we treat this child early in the process, we definitely can save the child sight from early on. So it is remarkable decrease in cupping can be observed as early as 1 week in some cases if it is early glaucoma. Pediatric glaucomatous cupping, the younger the child, the faster the reversibility, and its occurrence can be used as a main criterion of glaucoma follow-up in infants. And again, it is related to mechanical changes rather than glaucoma damage. So optic nerve head assessment is an extremely important and probably in some cases the single most important criterion for diagnosis and follow-up of early onset developmental glaucoma cases. The setting in the newborn in the operation room, and then in the adult, or sorry, in the older child. Angle examination is very important. We know the goniogenesis, and probably it was talked before in the first episode, but then we will also need to examine the angle very well, either at the operating room or in the in the theater, or sometimes if you are able to in older children follow up in the office. So this is for examination, and then we go back to dear Dr. Nader to tell us about the differential diagnosis of congenital glaucoma or early onset developmental glaucoma.
Okay. Thank you very, very much, Professor Khalil, for this really difficult task, simplified and made very easy for the listeners. Thank you very much, sir. Now, let's present in quite a few minutes the differential diagnosis of childhood glaucoma. That is, in simple, does any child that presents with a large cornea or a watering eye or whatever other manifestations of childhood glaucoma, does it essentially have to be a case of childhood glaucoma? In other words, what are the other conditions that may mimic childhood glaucoma? That is, in other words, in scientific terms, the differential diagnosis. So the child may present with the, let's use the lay term of the parents, an abnormal color of the eye. This abnormal color of the eye may not necessarily be a corneal edema resulting from an elevated intraocular pressure. It may represent simply a case of mucopolysaccharidosis, which is a storage disease, and these are very characteristic with their characteristic faces, as we can see in their cloudy corneas with normal intraocular pressures and normal optic nerves. Congenital hereditary endothelial and stromal dystrophies, as we can see in this child as an example, and in this other cloudy corneas, in which the condition is stationary, not progressive, everything otherwise is normal except from a cloudy cornea. And of course, the birth trauma from forceps, which is exceedingly rare these days in view of the switch to CS or cesarean section in cases of difficult labors. What about watering eyes? Well, this may simply be a congenital nasolacrimal duct obstruction, may not necessarily be watering with intolerance to light, which is a hallmark for photophobia and the presence of corneal edema rather than just a simple obstruction of lacrimal drainage pathways. What about large eyes, big eyes, ophthalmos eyes? This may simply reflect a congenital meliarocornea, as we can see in these 4 eyes. Actually, these eyes have otherwise completely normal features. Or simply a congenital high myopia. Sometimes the child may present with a defective vision due to high ametropia, or there may be an accidental discovery of some optic disc abnormality, which may not necessarily reflect a glaucomatous cupping, but rather another congenital optic nerve anomaly, such as a congenital optic nerve pit, a congenital glaucoma of the optic nerve, morning glory anomaly, or things like that, which may appear as an optic, which may mimic or look like glaucomatous optic affection. So, as highlighted by Professor Khalil, and we would like to emphasize again, intraocular pressure above normal, a larger axial length for age, and abnormal cupping for age, and all these coupled with progression over time are key to the diagnosis of childhood glaucoma. Otherwise, other factors should be considered in the differential diagnosis. So, thank you very much, and we may I invite Professor Khalil for the next talk on the medical treatment, or let's take a break with our sponsor, Orchidia, please.
Hello, doctor. Greetings from Orchidia Pharmaceutical Company. I hope you, your family, and all your beloved ones are safe and in good health. Today, I'm going to talk about glaucoma patients. Twinzol brings patients to the targeted IOP regardless of their baseline. Twinzol reduces the IOP by 30% for patients whose IOP is more than 25 mm mercury. And for those whose IOP is more than 30 mm mercury, Twinzol could reduce it up to 50% of the IOP. Another product for your glaucoma patients is Alpha Nova. Alpha Nova is the perfect add-on therapy with a superior neuroprotective effect, along with less incidence of ocular allergy, as Alpha Nova is preserved with sodium purite. Finally, I would like to remind you with OcuGuard, a tailored formula of vitamins, minerals, and herbs. Thank you for your time.
Thank you, Orchidia Farm, for the sponsorship, and please may I invite Professor Khalil to talk to us about the medical treatment about childhood glaucoma. Professor Khalil, please take the lead. Thank you.
Thank you very much, dear Professor Nader. So we talk about medical therapy for the management of congenital glaucoma. Is there a role? We know little about the long-term effects and complications in infants of all anti-glaucoma drugs. And what about their efficacies? So we have beta blockers, the topical carbonic anhydrase, prostaglandin analogs, the alpha agonists, and the cholinergics. These are the most available. But maybe the most important thing we would like to highlight in this brief talk is the alpha agonists. Alpha agonists, I'm going to mention again the beta blockers. Sorry, I will wait for the alpha agonists for now. The alpha agonists in infants cause CNS depression. Reported in literature, 1 case of death, sudden death. And I have personally seen children coming back from the intensive care unit because they have received liberal alpha agonists for their congenital glaucoma. I personally have seen many cases who come drowsy and sleepy, and I see the mothers and the parents coming with the drugs the child is having, and then I find the alpha agonist, and then I hold the drug. What about this alpha agonist? Is your child sleepy? Oh yes, he sleeps very well since we started this treatment. He is drowsy all the day long, and so on. So it ranges from some sleepiness, drowsiness, to CNS depression, which drives to the intensive care unit, as I have personally seen with some children, to sudden death, which is reported in literature. So alpha agonist is simply a total absolute indication in children, never use in congenital glaucoma cases. Probably you can try using them actually not before 10 years, very rarely before 10 years, maybe after the age of 7 and very watchful eyes, but I would not recommend till passage of 10 years. So again and again and again, alpha agonists with all forms are an absolute contraindication in congenital glaucoma eyes. Beta blockers carry risk of respiratory distress and bradycardia if they have a heart block. So respiratory distress, if the child has no asthma, probably it is safe. So this leaves us with topical carbonic anhydrase inhibitors, and we have many, prostaglandins, and the cautious use of beta blockers. These are the drops which we can use as a temporary measure before encroaching on our surgery. A child comes and you are not ready to operate for a week for any reason, then you can use the medical therapy for this temporary period. Treatment is essentially surgical, and I invite Professor Yasmine to talk about our surgical options.
So my talk is going to be on the choice of surgery in pediatric glaucoma. And starting by PCG, which is the most common, as you can see, the angle here looks very different from what we see in adult eyes. The immature angle responds differently to the different glaucoma procedures than adults do. And that's why we tend to target the angle more often than we do in adults. So the surgical options could be angle surgery, where you address the angle problem through surgeries that target the Schlemm's canal, the inner wall of Schlemm's canal and the adjacent trabeculum. Sometimes it may be appropriate to bypass these pathways with a trab or a tube procedure. And in certain situations, a cyclodestructive procedure may be the most appropriate. So as a primary procedure, angle-based surgeries have always been the standard, gold standard in glaucoma, especially in primary congenital glaucoma. By incising the trabeculum and the inner wall of Schlemm's canal, the aqueous gains better access to the collector channels and distal outflow pathways. In addition to that, in children in particular, the incision results in falling back of the iris away from this immature angle, and so the angle becomes significantly wider. This can be performed through either an ab-interno approach. If you have a clear view of the angle, you can do a goniotomy or a GATT procedure, or through an ab-externo approach. Usually, if the angle visualization is not clear, you perform a trabeculotomy. The success rates are variable. So as you can see here, I'm quoting this study by Al-Hazmi and co-workers from Saudi Arabia. As the glaucoma becomes more severe, the success rate is markedly reduced. So angle surgery works very well in mild to moderate glaucomas. In advanced disease, it's less likely, it's more likely to fail. So we looked at the risk factors for our cases in Abu Rish Hospital. Out of 452 eyes that underwent goniotomy and trabeculotomy, more than half of the goniotomy cases required another glaucoma procedure within the 3-year follow-up period of the study, whereas the trabeculotomy success rate was 70%. So looking at the different risk factors for failure and for less IP reduction. In the goniotomy, it was mostly related to the cupping. The more advanced the cupping, the less likely was the surgery to succeed. Whereas in trabeculotomy, there was a lot of adverse prognostic factors. The most significant on multivariate analysis were, interestingly, the female gender. So females are less likely to do well with angle surgery than males do. Positive consanguineous parents, younger age at presentation and at surgery, a higher preoperative IOP, and a hazy cornea were all adverse prognostic factors for the success of trabeculotomy. So all these factors collectively contribute to a more aggressive disease that is possibly more likely to scar. But then other factors like the collector channels health and patency that we know little about. So collector channels, we know that in adults, they're in charge of 1/3 of the resistance to outflow. We're not sure if we can extrapolate that in children. There are some studies that are trying to evaluate the health and patency of collector channels in adult eyes to be able to individualize treatment to those who can benefit more from angle surgeries. Maybe if we can use those more, we'll be able to benefit our patients better by knowing who would respond to an angle surgery more as well. But for now, it remains an obscure part that we can only know after the patient undergoes the surgery. Of course, for patients with very advanced disease, it may be more appropriate to go ahead with a cyclodestructive procedure if you think the visual prognosis won't be that good, or a tube procedure when you think that angle surgery will not work. Now, extent is an important thing. Extent matters. There's a growing body of evidence that points to the fact that the bigger the extent of the angle surgery, the more likely it is to succeed, which makes sense because it's less likely to scar, and even if it scars over time, there will be patent parts of the angle that are still functioning. Plus, you allow more aqueous to bypass the obstruction and reach the distal outflow pathways. So you may choose to use it as a primary procedure. I personally do that. Some people prefer to reserve it for patients with multiple risk factors or for redo cases that have failed conventional angle surgeries. Now, looking at angle surgery in secondary pediatric glaucoma, angle surgery has been shown in several secondary glaucomas to be successful in the child. So in aphakic glaucoma, it's been reported to have a success rate as high as 70%, according to Friedman and co-workers who've used the illuminated microcatheter circumferential trabeculotomy in their cases. Recently, we published a study from Abu Rish Hospital on the one-year results of circumferential trabeculotomy in glaucoma following cataract surgery on 33 eyes with aphakic and pseudophakic glaucoma. The success rate was amazing at 90%. So only 10% required another intervention within 1 year, and 50% were off medications at 1 year. There are other secondary glaucomas that have been reported to do well with angle surgery as well, including Sturge-Weber syndrome, microspherophakia. So really, any secondary glaucoma is worth attempting an angle surgery in, unless it has extensive PAS where you think it's a low prognosis procedure. So is primary trabeculectomy an option? Well, the answer is no, especially in primary congenital glaucoma. These pediatric eyes have characteristic features. They have a thickened tenon, they have a more aggressive healing response, and they're more likely to encapsulate and fail, whether early or later. The sclera in these ophthalmic eyes is thin, so when you dissect it, you may end up with a less than an ideal flap that may even become more problematic as time passes. And the stretched limbal anatomy makes it sometimes difficult to identify the limbal landmarks, so these eyes are more likely to complicate. And finally, most importantly, the risk of infection from leaving a bleb, which is really a ticking bomb inside these eyes over their lifetime. So the New York Eye and Ear Infirmary published a study on looking at the results of trabeculectomy in 29 patients in their series, and 5 of these, an appalling 5, had late bleb-related infection after an average of 2.5 years, and 2 of these were frank endophthalmitis cases, and that's in addition to other complications including retinal detachment, suture abscess, and phthisis. So for these reasons, when the World Glaucoma Association came up with the consensus, met up for the consensus series on childhood glaucoma, they strongly advised against doing trabeculectomy as a primary procedure in children, especially in PCG patients. So now, what if the angle surgery fails? First of all, of course, we wait for a little bit, at least 1 month, but usually more than 3 months. Give it a chance, make sure that there's not a steroid response that's been raising the pressure. If the primary procedure was a conventional 180-degree trabeculotomy or goniotomy, then you can go ahead and treat the whole angle with a circumferential angle surgery. There is evidence that suggests that the success rate is quite high, 77% in eyes that have had circumferential trabeculotomy after a previous limited extent angle surgery. And not just that, but also after bleb-based procedures like trabs and tubes, these eyes can go back to having a proper circumferential angle surgery. We do receive a lot of cases, unfortunately, that have had a trabeculectomy as a primary procedure, and when it fails, these patients, we go back and do an angle surgery, whether after a trab or a tube. And even the cases with clear cornea, you can go back. So this is a patient that had a tube surgery before and never had a proper angle surgery. So for this patient, a GATT was a proper, gave him the best chance with a minimally invasive procedure to lower the pressure despite the presence of a tube. So what if the circumferential angle surgery fails now? Now this becomes really problematic, and because all the remaining options are less than ideal, most of them are either cyclodestructive or bleb-based with all the complications of blebs, and that's why it's really crucial to give children the best chance with the first procedure, because this is likely to last them for a lifetime, versus if they start going on the way to bleb-based procedures, they usually end up having multiple glaucoma surgeries with all the risks. So the choices are to do a trab or a tube, and Friedman and Beck looked at the results of those, and they found that at 6 years the tube group did much better in terms of success rate and IP lowering. So tubes are possibly a better option than trabs. What if a trab fails? Would you redo it? Most of us will go ahead and do a tube, but if you think that the visual prognosis is poor or the conjunctiva is healthy, maybe cyclodestruction would be the only option. Finally, what if the tube fails? You can either reimplant another tube in another quadrant or do a diode. When Beck and Sood looked at the results, compared the results of both options, they found that they were compatible. There were different complications in each group, and they recommended that we should tailor the treatment according to the individual patients. So to conclude, angle surgery is the procedure of choice as a primary procedure in both primary congenital glaucoma and most of the secondary pediatric glaucomas. A circumferential surgery yields very good results, even if your patient already had a previous trab or a tube or a cyclodestructive procedure. Once angle surgery fails, the evidence is still scarce as to what's the next best procedure, and you often need to individualize treatment. But in selecting treatment for these patients, one needs to remember and consider the lifelong risks and benefits of whatever surgery we're choosing for these children. Thank you.
Now, Dr. Hala E will go with her goniotomy talk.
Thank you very much. I have no financial disclosures. Barkan introduced goniotomy in 1938. The concept behind goniotomy is to create an incision in the non-functioning or dysgenetic trabecular meshwork to facilitate the exit of aqueous from the anterior chamber into Schlemm's canal. Goniotomy has several advantages. It attacks the defective tissue, which is the dysgenetic trabecular meshwork, under direct visualization without jeopardizing conjunctiva or sclera. Both tissues are very dear to a glaucoma surgeon because they are needed for other procedures if this one fails. However, it requires clear cornea and incisors 120 degrees of the angle only. Potentially, it leaves residual TM leaflets which can readhere to one another and close up the angle again. If one decides to do goniotomy, it is important to clear the cornea. That can be done preoperatively using anti-glaucoma medications or intraoperatively by removal of epithelium in case of epithelial edema. This is the goniotomy setup. Now, the surgeon is seated on the temporal side of the eye that will be operated. The microscope is inclined at an angle of 45 degrees, and the head of the patient is tilted away from the surgeon. For exposure, I find the best thing is to place traction sutures under the superior and inferior rectus muscles. This stabilizes the globe, retracts the lids, and creates a good space for placing instruments and the gonio prism, unlike the speculum, which can exert a pressure on the eye, especially in a narrow palpebral fissure, and may increase corneal cloudiness. If epithelial edema is present and is impairing visualization, a drop of 70% alcohol is placed on the center of the cornea, and then a dry cellulose sponge is used to sweep away or remove the central part of the corneal epithelium, leaving an intact trim at the periphery. In young infants that are 2 to 3 months old, it's a little bit more tricky to remove the epithelium. It is adherent and requires a little bit more scraping. This is the goniotomy procedure. I use a 25 or 27 gauge irrigating needle attached via an IV line to an infusion bottle. The tip of the needle engages trabecular meshwork very superficially and is then advanced circumferentially in an anti-clockwise manner and then in a clockwise fashion. There should be very little resistance to the movement and no gritty sensation, otherwise the incision is too deep. You can see the root of the iris and the lower leaflet of trabecular meshwork falling back. This is continued along for as much of the circumference of the angle that one can visualize at the procedure. The importance of using the infusion bottle is that if bleeding occurs, the infusion bottle can be raised to tampen at the blood and continue the procedure with a bloodless field. It's important at the end to make sure that there is no TM gap, bridging the gap. The needle is removed and the entry site is closed with a single 10-0 embedded suture. You can see the trickle of blood from the Schlemm's canal into the anterior chamber. Another case where we oftentimes see that the root of the iris is inserted above trabecular meshwork. These are a little bit more tricky to do. You place the tip of the needle just above the root of the iris and try to tease that angle open. I find it easier in this case to go from untreated parts of the angle towards areas that I've treated 1 to 2 clock hours at a time. And I repeat that process, and this is easier for me than going from treated to an untreated part. Postoperative care is important. If I'm doing a unilateral case, I turn the head of the patient to the same side. That will place the site of the goniotomy incision uppermost. It will allow blood to trickle away from the angle. And this will prevent accumulation of fibrin at the site of the gonio incision, which can end up in scarring and synechia. Steroid antibiotic eye drops are used initially at 6 times a day and then tapered over 4 to 6 weeks. And of course, one needs to watch out for steroid responders. Now, the results of angle surgery, goniotomy and trabeculotomy, are both very favorable in Western studies. Goniotomy is reported to have a success rate between 75 and 80%. However, the results in Middle Eastern studies are less favorable. Here are 3 studies with average or reported success rate about 50%. And this emphasizes the more aggressive form of disease that we have to deal with in the Middle East. Hazmi reported, however, that choosing cases with mild primary congenital glaucoma, the success rate is 81%. These mild cases have a preoperative intraocular pressure less than 25 millimeters mercury, corneal diameter less than 13, and good corneal clarity. And this emphasizes the importance of case selection in goniotomy cases to achieve success. This is a study coming out of Cairo University. 81 eyes were included. These eyes had a minimum follow-up of 4 years and mean follow-up of 5.9 years. And the mean age of surgery was 6.1 months. Cases were considered successful. A complete success if intraocular pressure postoperatively was less than or equal to 18 millimeters mercury without meds, and a qualified success if the same pressure was reached with meds. So the early success rate after 1 year of surgery was 69.1%. However, late failures occurred in 18.5%. The mean time to failure was 5 years. And this again emphasizes the need to continue monitoring these patients and following them up for a very long time. Long-term success rate was 50.6%. Risk factors for failure were positive consanguinity and surgery in the first month of life. There's another study coming out of Cairo University that Yasmine touched on before, and the failure rate was 56% with a mean survival time 17.6 months. We also tried to assess the efficacy of using the Kahoot dual blade in performing goniotomy. The instrument has a sharp tip that makes the initial incision in trabecular meshwork, and as it is advanced, the heel or the foot plate is rested against the outer wall of Schlemm's canal, and the ramp stretches and lifts trabecular meshwork to facilitate creating 2 incisions by the 2 sharp blades on either side of the instrument. Potentially, using the Cahoop dual blade will excise a strip of trabecular meshwork. This results in a near complete removal of trabecular meshwork and potentially reduces the scarring and fibrosis of residual trabecular meshwork leaflets. This is a case where, which was operated using the mark and meet technique. The anterior chamber is deepened with viscoelastic. The Cahoop dual blade is advanced across the anterior chamber, and an initial incision is made with the tip of the Cahoop dual blade. This is the primary incision. A second incision is created to the right, 2 to 3 clock hours to the right of the first incision, and then advanced towards the first incision. And when it meets the first incision, a strip of TM is created. You can see the strip here. Now, you can repeat that procedure, and by doing so, end up with several strips that are either loose in the anterior chamber or adherent at a point, and can either way be removed with a 23 gauge forceps at the end of the procedure. This is another case where the Cahoop dual blade again is introduced in Schlemm's canal, and you can see the outer wall of Schlemm's canal, the white appearance of the outer wall, and a second incision to the right of the first one is then created to meet the first one, 2 to 3 clock hours. And you can see that as it advances towards the first incision, you will find a strip of trabecular meshwork present in the anterior chamber. This again is repeated, and in this case, you will find a strip of trabecular meshwork still adherent to the wall of the angle, and the attachment was severed using the sharp blade, and you can see the strip of TM here, and this is several strips can be removed using 23 gauge vitreoretinal forceps. So the Cahoop dual blade ab-interno trabeculectomy was easy to perform. It controls the depth of tissue removed, and that I find is true about that procedure. It can excise a strip of TM, but in order to do that, you have to really place the footplate against the outer wall of Schlemm's canal with no tilt, so that both blades are parallel and therefore can create 2 parallel incisions. Is it better than conventional goniotomy? At the moment, we are finalizing the results of a study that compares conventional goniotomy to goniotomy using the KDB. With a year of follow-up, and we hope that we will be able to publish our results soon. Finally, I think in my mind, ab-interno is my first choice. This is because it attacks the defective tissue directly under direct visualization without jeopardizing conjunctiva or sclera. It does not prejudice the success of future surgery. Less traumatic, it's safe and short, and can be performed bilaterally. Of course, this is true in the proper selection of cases for goniotomy. Thank you.
Thank you very much, Professor Hala, for this excellent presentation for angle surgery, a really important issue of pediatric glaucoma surgery. And now we invite Professor Khalil to deliver us a talk about the modified trabeculotomy. So, Professor Khalil, please take the lead.
Thank you very much. So we would like to convince you today that angle surgery is the choice, whether you do it ab-interno goniotomy and its modifications or ab-externo
Should be the title of the session, sir.
And modifications. Yes, thank you, Nader. So we have, again, many cases of congenital glaucoma in Egypt and in the Middle East in general. And we see them from early on to later on in life. This is probably Professor Yasmine has mentioned, and Professor Hala as well. This is the regular circulation that comes from the ciliary processes and flow into the anterior chamber, the aqueous, until it comes into the trabecular meshwork and into the Schlemm's canal and the aqueous veins. So this is the Schlemm's canal representation around the eye, and the aqueous veins draining from these Schlemm's canals. So we have the pathology between this canal of Schlemm and the anterior chamber. So we would like to go in and sever this tissue, which is the trabecular meshwork. And we can do this with trabeculotomy. Angle surgery actually is very old. It dates back to the late 19th century by an Italian oculist whose name was Differential. And he recommended angle surgery for all types of glaucoma then, but his work passed unnoticed until Otto Barkan in the 30s revived it. And the first trabeculotomy was mentioned simultaneously by several authors, but I quote here Redmond Smith of the UK, and this is his first description of trabeculotomy, and it was a thread trabeculotomy through 3 incisions. Trabeculotomy has developed very much since then, actually, with various techniques, and the technique I'm going to show today is one of these modified techniques I call adjusted trabeculotomy. So this is the angle. This is the angle under electron microscopy. I like always to bring this slide. This is the angle of the anterior chamber. This is the trabecular meshwork, and this is the canal of Schlemm. So again, if we remove all this like we do in penetrating trabeculectomy, penetrating surgery, we invite fibrous tissue coming from the outside, and it doesn't work. And if we do non-penetrating surgery, like any non-penetrating surgery, we remove this part, but the pathology is here. So what is the use? And if we remove this part, which is the trabecular meshwork, so probably this is our target. The technique of trabeculotomy is a little bit adjusted trabeculotomy. I always do in all my glaucoma surgeries, limbal-based conjunctival incision, superficial scleral flap, incising the canal of Schlemm after we go in it, and then we simultaneous probing of both ends of the Schlemm's canal. We have the advantage of simultaneous probing, and with these handleless trabeculotomy probes, we go on with the probes right and left, and we rotate them so it is easy to go on either side, because after collapse of the anterior chamber, it becomes really difficult to get the canal of Schlemm from the other side. So we have to make good exposure by corneal traction sutures, and I prefer to take 2 bites actually to have this smooth lowering down of the eye, and then this is the limbal-based conjunctival incision, and I make again another traction suture. This takes actually quite a bit of long time, but it pays back. And then we do the superficial scleral flap, and I insist on making a usual scleral flap in these eyes with gentle dissection. And then we try to make this radial incision to find the canal of Schlemm. And you can find the canal by exposure like this, sometimes very gentle egress of aqueous, sometimes egress of blood because of the hypotony in the eye, which ensues after the opening of Schlemm's canal, so blood regurgitates back from the aqueous veins, and this is very gentle aqueous egress, and the egress of blood, very gentle egress of blood here. So all these are good signs that you are in the canal of Schlemm. And then you introduce the trabeculotomy probes. And the very big advantage, these are very lightweight, so they are very, very difficult to maneuver. But again, you are very, very sure they are similar to thread trabeculotomy, but have the sturdiness of a rigid trabeculotomy probe. And here I did not yet go into the anterior chamber. One probe is inserted and the other probe is inserted, and you see the shape. It should go easily if you make the good proper circumference of the probe. You see here, now you are sure in the canal of Schlemm. Where else can you be with these near microscopic trabeculotomy probes? You are sure in the canal of Schlemm, and then when you rotate these, then probably you will sever, for sure, not probably, the canal of Schlemm. So now both probes are in place before entering the anterior chamber, and then when the tip starts first, this is a very good sign, and this is hyphema. I always call my lovely hyphema because it's a very nice and gentle sign of my success in severing the trabecular meshwork. You see gentle hyphema here, and gentle hyphema will ensue here, my lovely hyphema, one of the sure signs again that we are successful. I do this technique actually even from the temporal side, as you can see here. If this child has done previous surgeries, including any surgery, I do this even after tube surgery, and it has a good success rate even after more vigorous or more I say sorry for the word, violent surgery of trabeculectomy or valve surgery in these eyes. These eyes need very gentle attention and surgery. Appearing of the tip first, not the whole probe, is a very good sign, and this ensures that you all again are severing the trabecular meshwork. And then I make tight closure because this is mainly an internal filtration. So tight closure of the scleral flap, followed by tight closure of the conjunctiva again. So at the end, there is no sign. And many cases, when few years later, you cannot detect any sign of surgery. This is a movie which I would like to say, this is the inside of the eye, inside of the anterior chamber following trabeculotomy. And this is, if we move the gonio lens, we here see the goniogenetic part illustrated before. And then if we move again, this is a goniotomy, but not performed by Professor lhilali, of course, but because this was not a very accurate trabeculotomy, we see the adhesions and so on, which are, sorry, goniotomy. So this is a post-goniotomy picture of the angle. We hear about the aqueous veins. This is the aqueous vein coming from inside the eye. These are the conjunctival veins. This is the aqueous vein coming from the canal of Schlemm to the eye, and I'm going to demonstrate to you. After, now you see, this is the passage of the aqueous vein from inside to outside of the eye. And when you see, I'll make a pause here, you see this is the canal of Schlemm, not yet open, but here again, this is the aqueous vein. So it is coming here from the canal of Schlemm, this line is bringing the aqueous veins, and then it comes out into the subconjunctival space. And when we depressurize the canal of Schlemm, blood comes back from the aqueous veins and come into my incision. And again, this is the regurg back of the aqueous from the aqueous vein blood. And this is, by the way, also the reason for what I call my lovely hyphema. So this is the picture I showed in the examination part, and we see the edema with medical treatment. These are bands, opaque bands of the cornea. And after, sorry for that, and after treatment, and after surgical treatment, you see this is after conclusion of the surgery, and this is few weeks later with total clarity of the cornea and abscess striae present. So surgical treatment by this technique is very rewarding, and I hope we can meet in one of our meetings in the beautiful city of Luxor in southern Egypt. See you after the end, inshallah, nearby end of this COVID epidemic. And Professor Yasmine has another technique of trabeculotomy, which she is going to present the whole 360 degrees angle surgery.
So my final presentation today is going to be on circumferential Schlemm's canal procedures in children. And interestingly, the first trabeculotomy ever described was a circumferential one, but for some reason it did not gain popularity. And in the same year, when Allen and Bourrian described their trabeculotomy, conventional trabeculotomy with the rigid probe technique, it became the standard procedure and was adopted since then. But then over the past few years, with the introduction of the illuminated microcatheters, the interest has started to rise again in addressing the whole angle circumferentially. And all the studies that have compared circumferential trabeculotomy with the microcatheter to conventional trabeculotomy or goniotomy have shown superiority in terms of success and IP reduction with when treating the whole angle. Up with a reproducible technique for circumferential trabeculotomy were Beck and Lynch in '95, where they used a Prodi suture threaded through the Schlemm's canal externally after creating a scleral canal to identify it. And the tip of the Proli suture, whether 5-0 or 6-0, is blunted out with cautery, and you keep on threading it throughout the Schlemm's canal. The angle view is clear, the cornea is clear, you can track it with the gonio lens, but in cases like these with opaque corneas, it becomes a completely blind procedure. And once the other tip comes out of the Schlemm's canal, you grip both and you incise the canal circumferentially. So obviously it's a blind procedure with a lot of reports of creating false passages into the suprachoroidal and subretinal spaces. But interestingly, in these studies, there was no damage, no retinal detachment, no severe complications that resulted from this misdirection. But then again, you really want to know where your suture is going. So with the introduction of the illuminated microcatheters, we started being able to track the passage of this thread circumferentially as it illuminates the path of the microcatheter. So the eye track and the previously available glucolite have allowed us to visualize the illuminated tip as it's being threaded through Schlemm's canal. And as it proceeds parallel to the limbus, you can spot it all around the limbus. And if it stops at some point, you can identify where it stopped and be able to retrieve it. And once it comes out of the opposite end, again, you grip both ends and you incise the canal circumferentially. As I said, a lot of studies have shown superiority of the microcatheter technique, and in Abu Rish Hospital, we ran a prospective study over 2 years that compared the microcatheter-assisted trabeculotomy with the glucolite to the rigid probe trabeculotomy, the conventional 180-degree, and the success rates were 85% compared to 50% with conventional trabeculotomy. And that was not at the expense of a high risk of complications. So none of the studies have shown a high risk of complications when treating the whole angle. There are some drawbacks of the microcatheter, of course. In addition to the costs, we noticed that it's more likely to become misdirected, being thinner and more fragile, more likely to become misdirected or stop on the way than the rigid metallic trabeculotome. And very often we had to, when the microcatheter stopped on the way, we had to complete the incision with the rigid probe trabeculotome. So when we ended up with this result, we decided, so why not do the whole procedure with the trabeculotome circumferentially using a two-sided technique, which was previously reported in literature years ago. And what we do now as routine in cases, especially those with opaque corneas indicated for trabeculotomy, is we create two simultaneous trabeculotomies 180 degrees apart in the same sitting to cover as much of the angle as possible. Usually the first one is located in the based on the supranasal quadrant to avoid the superior conjunctiva, which may be needed for a subsequent trabeculectomy, and the supratemporal, which may be needed for a tube. And then the other incision, the other trabeculotomy is based on the infratemporal quadrant. We tend to deroof the Schlemm's canal to be able to visualize its floor, make sure it's patent, make sure that it's actually Schlemm's canal, because again, there are a lot of false passages where the probe can go through. So it's much safer to visualize where you're going before you proceed with the probe parallel to the limbus. And once you're in, you go in strictly parallel to the limbus, making sure that it doesn't proceed and penetrate the anterior chamber prematurely, because you can start properly inside Schlemm's canal, but then cut the course short by penetrating the AC before you reach the tip, the end of the probe, or you can misdirect posteriorly into the suprachoroidal space. And when we compared the two-side technique retrospectively to our microcatheter cases with the glucolite, we found that the results were comparable. They both created circumferential trabeculotomies in different ways. Actually, the two sides yielded slightly better results, but that was not significant. So this is what we do as a standard procedure, more or less now. The drawback, of course, is that you violate the conjunctiva with these ab-externo procedures. And so for this reason, Davender, Grover, and Ronald Feldman, around 5 or 6 years ago, came up with the GATT procedure, which stands for gonioscopy assisted transluminal trabeculotomy. So this is basically an ab-interno circumferential trabeculotomy that you create using a Pauline suture or a microcatheter. So you create a goniotomy-like incision, endoscopic view, and then you thread the Pauline, usually 5-0 suture, again with the blunted tip with cautery. You insert it through one of Schlemm's canal. Of course, speeding up here the procedure, but it's quite, if it goes smoothly, it's a quite quick procedure that can take 5 to 7 minutes to perform. And then the suture starts reappearing from the opposite end. As you can see here, it's covered by the fragile inner wall of Schlemm's canal, and then cutted circumferentially. You can do that with the Proline suture or with the microcatheter, whether the iTrack, which is available now. And the results have been fairly good. Feldman and Grover, they published their results in primary congenital glaucoma and juvenile open-angle glaucoma. Although there aren't too many eyes, but hopefully in the near future there will be more studies. But we can expect it to be at least as good as trabeculotomy, circumferential trabeculotomy, but with the added benefit of being performed through an ab-interno approach with no violation of the saliva and through an MBR incision. And finally, Sight Sciences came up with device that can create, again, a circumferential incision. They called it TRAP 360, and it consists of an injectable, non-illuminated microcatheter that you inject on one side of Schlemm's canal and use it to incise the canal over 180 degrees, and then you go back and inject it on the opposite side and incise it over 180 degrees. There's been one published about that actually in the APIS meeting, the last APIS meeting in 2019, and the success rate was around 70% in pediatric eyes. So to conclude, circumferential Schlemm's canal surgery, whether using a microcatheter, a rigid probe, trabeculotome, or a suture, whether through an ab-externo or ab-interno approach, has really improved the success rates of angle procedure, especially in primary congenital glaucoma. There's no evidence that the risk of complications is higher with circumferential compared to conventional otomy and goniotomy. So you may choose to use it as a first-line procedure or still reserve it for high-risk patients or recurrent patients, recurrent glaucoma after angle. Thank you.
Thank you, Dr. Yasmine, very much for this very informative talk. And Professor Hala has some experiences that she would like to share with us about her adventures with angle surgery. So please, Professor Hala, take the lead.
Thank you very much. I want to thank Yasmine for teaching me how to do the GATT procedure, actually for insisting that I learn how to do it, and for the enthusiasm that she showed in teaching me this procedure. It doesn't always go the way Yasmine showed. Sometimes there are adventures. It may be because we are still learning how to do it, or maybe it's something that is inherent to the procedure. So I'm going to show you this movie of my adventure with a GATT. I'm sorry. So anyway, this is it. After creating the initial incision with an irrigating needle in trabecular meshwork, the 5-0 Proline suture with a blunt tip. The blunted tip is introduced and threaded into Schlemm's canal using the microforceps, and that is going quite smoothly here. I'm very happy, thinking that it's coming up the other way, and I could see it. But as I hold it, I realize that it's not in Schlemm's canal. The distal end is not coming from Schlemm's canal. It was actually resting in the angle, but in the angle recess, but on the surface of the iris, not entirely in the canal. And so I'm trying to figure out here where it exited from Schlemm's canal. And as I'm holding them, you can see that almost I can detect that it's probably exited just under my initial incision in temporal cornea. And so I changed the position where I'm sitting to try and figure out where it was, and I could see it right there. So it was really almost at the site of the incision, at my initial incision, and I was able to complete a little bit over 180 degrees of threading it into Schlemm's canal before it exited from it. I created another incision, used the microforceps to hold the 5-0 Proline, and was going to pull the two together, as you see here, and maybe continue incising the rest of the angle as a conventional goniotomy. Then I noticed that there was a thread. It was actually a strip of trabecular meshwork and inner wall of Schlemm's canal, and so I held it with forceps, and I'm now stripping it from the angle, and that helped me to increase the amount of incised angle that I was able to perform for another 90 degrees. And this is the strip of TM with the inner wall of Schlemm's canal that I was able to retrieve. And by doing that, I performed 270 degrees of GATT. And I thought I would share that adventure with you. I also have to thank Dr. Ghada Gaudat for her participation in the trio that we perform surgeries with on Sunday, and the camaraderie that the three of us have, which is really adding to the enthusiasm of the glaucoma service. So thank you both very much.
Thank you very much, dear Hala, for these nice videos. Very interesting. And I would like to mention that this is our 6th episode of glaucomatology. And as we mentioned in the beginning, that we are dividing the CME accreditation into 2 parts. So you have to attend 6 episodes, minimum 5, to take the credit hours of the first part, which is 6 hours. And there will be a test which will be sent to you by email during this week. And the CME examination will be next Saturday. So just after the next glaucomatology part, it will be on Saturday, just a second. So 8 days from now, the Saturday on the 17th, from Friday of the 16th, from 10 a.m. to 10 a.m. the following day, which is Saturday the 17th. The CME test will be available for you to answer along a full 24 hours. So together with attending at least 5 sessions, you will be able to get the credit hours. Now we leave you with a short intermission with Orchidia, our sponsor, and its products.
Hello, doctor. Greetings from Orchidia Pharmaceutical. I hope you, your family, and all your beloved ones are safe and in good health. I'm going to talk about dry eye patient, especially who is associated with itching. Orchidia offers the integrated solution from Orca-P-Post and PolyFresh Extra. Orca-P-Post is anti-aging and anti-allergic agent, which is not only has exceptional antihistamine effect, but also has a novel special mechanism as anti-aging agent by inhibiting nitric oxide secretion at nerve endings. The second arm of our solution is PolyFresh Extra, which is a unique combination that gives extra hydration effect and balancing the tear film osmotic pressure, in addition to the anti-inflammatory effect of glycerol. Thank you for your time.
So again, as I mentioned earlier, we are trying to convince you that angle surgery is the answer for glaucoma in the infant, whether you do it from inside the goniotomy, the modern techniques, the partial trabeculotomy as I do, or the 360 degrees trabeculotomy Yasmine does. So all these are good options. But we all, as pediatric glaucoma surgeons, also see a lot of regular trabeculectomies done in infant eyes, and though sometimes it can be successful, they are usually associated with much complications which can be actually lifelong and everlasting. So Professor Nader will talk us through some of these complications which he encounters in his practice. Nader, please.
Thank you very much, sir. Now, although we're running late, I'm still trying to convince the audience that trabeculectomy is not a good choice for child in glaucoma surgery. And let's have a look quickly on a number of complications that were encountered by surgeons during trabeculectomy in childhood glaucoma. So essentially, childhood glaucoma is a surgical disease, and there is no consensus on the ideal surgery after the angle surgery, of course, and irrespective of the procedure, a number of operative steps are common to more than one procedure. Complications do happen, and let's have a look at some of the intraoperative complications encountered. So the complications may start in the very beginning with the exposure of the operative field. If you're used to taking a corneal traction suture in an adult eye, remember that the ophthalmic eye, it is evidence-based already that the corneal thickness is thinner than normal, and it is thinner than the adult eye. So not uncommonly, as you're trying to take your corneal traction suture, you may perforate inside the anterior chamber. Now watch this surgeon as he advances the needle, and watch immediately the amount of fluid present in the field just as the tip of the needle exits the cornea. You see this egress of fluid just as the tip of the needle exits the cornea. That surgeon has penetrated the AC while doing the traction suture because he or she did not estimate the thickness of the cornea. So complications can start from the very, very beginning. The next is expected or encountered complication, as you can see, is you're used to an intact cornea, corneal stroma with corneal epithelium in the adult. So the corneal traction suture would hold the tissues of the cornea. But in a pediatric eye and in a ophthalmic eye, you're dealing with edematous tissues that may be friable. So you can see this amount of cheese wiring of the corneal traction suture into the cornea. Remember that you've not started the surgery yet. You're just exposing your operative field, and yet you can end up with these two simple complications that can make you abort the surgery, actually. Paracentesis is an essential step. Take care that you don't, the paracentesis step may result in giving way into the eyes. You can see the surgeon is trying to go in with the super sharp blade and then suddenly a giving way. That giving way might very well injure the intraocular structures, namely the iris, and if you're operating an eye that harbors any dysgenesis, the iris may not be there, there may be a partial aniridia, and you may end up hitting the lens at, again, the very, very beginning of the surgery. The tract may be overtly narrow, or there may be leak of aqueous humor, as in this video. As you can see, the anterior chamber is continuously losing, the eye is continuously getting soft, that the surgeon cannot even dissect a scleral flap, and the surgeon is repeatedly forming the anterior chamber through injection into the anterior chamber all the time in order to be able to continue the surgery. So what about the conjunctival peritomy and dissection? Let's look at this surgeon very enthusiastically dissecting the conjunctiva, maybe trying to remove the tenon. This was actually a reoperated eye. This is not the primary surgery, but again, that surgeon was trying to make a conventional trap. So very enthusiastically trying to dissect the tissues, the fibrosis, the tenon, and then let's have a look at this coming surprise. Very interesting jack in the box. You see that majestic bottom hole? A real catastrophe, as we can see. Liable to occur in pediatric glaucoma surgery as well as in other glaucoma surgery, but is really catastrophic in children. While you apply the anti-metabolite, if you're planning to do a trabeculotomy, you might as well consider using an anti-metabolite. This is an almost unedited video. I have not edited the number of sponges, but if you count the number of sponges inserted here, you'll find that the surgeon has inserted one more sponge than he has removed. So you can very commonly forget one of the sponges behind. Again, another catastrophe, because mitomycin is known to be cytocidal. It can cause actually melting of the sclera, melting of the conjunctiva. It can end up with a real catastrophe. So this is, again, honestly, this is an unedited video. We have not deliberately removed one of the sponges during removal. Just count the sponges as they're being removed. There is one sponge left behind. The surgeon is still overtly enthusiastic, overzealous, adding more mitomycin, really wanting to perform a really nice filter. And then let's count them while they're being removed. Nice and decently put in place. And then as they are removed, more and more. This surgeon really impresses me. How much does he think he's going to put inside this eye? Obviously, the surgeon and the assistant have lost count in this case, and while they're trying to extract the sponges, there will be one left behind. So, for the sake of your time, I'm going to skip this, but take my word, they're going to forget one of the sponges behind inside this operative site. Okay, now again, if you're an occasional pediatric glaucoma surgeon, you're doing a trabeculectomy routinely, and you attend this webinar, and you attempt to make your first angle surgery without any prior training or experience, and this is what you end into. You're trying to make the radial incisions to find Schlemm's canal, and let's watch this again. You're actually perforating inside the anterior chamber, you're not finding Schlemm's canal here. Okay, so you're not going to be able to do the angle part of the surgery if you're planning to do it without training. Again, if you just manage by chance to find Schlemm's canal, Professor Khalil demonstrated a very simple and easy sweep of the trabeculotomy inside the AC. It's actually much easier said than done, and it's much easier said in the hands of experts as Professor Khalil. But if you're trying to do it as you are a novice surgeon, as you can see, trabeculotomy is just not getting inside the eye. And the possibilities are multitude. Maybe that surgeon is not inside Schlemm's canal, maybe something is just not going correctly, and the result is the trabeculotomy is not getting inside the anterior chamber and it's not doing the job that it's intended to do. The ostium of the trabeculotomy may present complications. We've seen this with Professor Yasmine. You see this knob of tissue? Guess what's this? I guess we all know from cataract surgery. This is vitreous. Where does vitreous come from? In a trab. Please allow me to present this once more. Even in a routine trab, if you're thinking that a trab in a child is routine, it's not routine. This is a vitreous knuckle coming out from an attempt to enter the anterior chamber during pediatric trabeculectomy. Finally, enclosure of the conjunctiva. The sutures have to be really tight because every drop of aqueous counts. Maybe the inadequate or the not very tight closure of the adult trab, based on the fact that the sclera is rigid and it will hold the conjunctiva. This is not the case in children. The sclera is not rigid, it will not hold the conjunctiva, and the closure, if it is not really tight, may leak aqueous, and the bleb is will not form. So the take-home message would be that childhood glaucoma surgery presents a real challenge that mandates significant skill, experience, and extreme attention to the finest details. It's not a job to mess with if you're not a routine pediatric glaucoma surgeon. So that concludes the talk about complications of an occasional trabeculectomy surgeon in a child. Thank you very much, Professor Khalil. Okay. So this would make us proceed with the next talk. Okay. Now, my final talk today would be about glaucoma after childhood cataract surgery. Childhood glaucoma after childhood cataract surgery has a lot of issues actually. In the examination, we have to highlight that there is no consensus in the studies about the cutoff level of normality for the intraocular pressure for the diagnosis of glaucoma after congenital cataract surgery. Actually, as Professor Khalil highlighted, that statistical normal of the adults of 21 millimeters mercury is not the case in children. It is much less. It is dependent on the age group, actually, the anesthetic that you use, the tonometer, the technique. There are a lot of variables. But end of the story or baseline, it's not the usual 21 millimeters mercury of the adults. Okay? So, as in all childhood glaucomas, except for eyes with advanced optic nerve damage, we have to look for progression or change over time. And as Professor Khalil highlighted, the most important parameter is the optic nerve appearance, whether you describe it by cup disc ratio, neural rim thickness, whatever you choose to describe the changes in the optic nerve, but it is the optic nerve that shows the major brunt. Then come the other parameters, namely the axial length, the corneal diameter, the refractive status, after, of course, raising the issue of the controversial issue of the intraocular pressure. Just a reminder, don't forget that the central corneal thickness after pediatric cataract surgery is significantly thicker than normal, and this may result in an artifactual elevation of the intraocular pressure, just to confirm the diagnosis. Gonioscopy cannot be overemphasized in such a case because there may be an associated dysgenetic angle, or there may be a complication of the pediatric cataract surgery itself in the form of peripheral anterior synechiae as an example. So gonioscopy should not be overlooked in such a case. So again, how to treat? Well, of course, we treat the glaucoma, not the rise of the intraocular pressure. Having mentioned so, we have to emphasize the importance of treating the cause, medical treatment, as Professor Khalil highlighted, and the surgical treatment. So what's the treatment algorithm or the treatment paradigm? The first issue, since we're dealing with glaucoma after cataract surgery, is to look at the visual axis, not because this affects the glaucoma, because this affects the visual outcome of the child. So there's no point in treating glaucoma in an eye that has an occluded or an obscured or a not very clear visual axis. It would be useless to normalize the intraocular pressure in such a case. So you'd first have to clear the visual axis, whether by doing an anterior vitrectomy, a membranectomy, just construct anterior segments so that the visual axis is clear, so that that eye would benefit from normalization of the intraocular pressure. Feedback this loop until you have a clear visual axis. Once the visual axis is clear, let's look at the anterior segment anatomy. If it's disorganized, again, you're at the same point again, just correct or make intact the anterior segment anatomy. Once we have an intact anterior segment anatomy with a clear visual axis, we then move to the next question, which is the glaucoma surgical procedure. We have to mention again that there is no consensus on the ideal glaucoma surgical procedure for glaucoma after congenital cataract surgery, bearing in consideration that angle surgery would still give the best results, at least as a primary procedure. But let's say, again, there's no consensus. So the algorithm suggested would be to look at the conjunctiva. If the conjunctiva is healthy, we would consider the gonioscopy, and the gonioscopy, we would consider the questions of the angle being mature or healthy or immature or unhealthy. The conjunctiva, if scarred, we look at the visual potential. Next issue, if the visual potential, whether the visual potential is good or poor. So if the conjunctiva is healthy and the gonioscopy reveals an angle that is mature and healthy, then we might consider, although we do not recommend that for the novice or the unexperienced pediatric glaucoma surgeon, we may consider filtering surgery with antimetabolites. Whereas if the angle is immature or unhealthy, which is most probably the condition in glaucoma following pediatric cataract surgery, then we might consider combining filtering surgery with angle surgery, whatever, ab-interno or ab-externo. If the conjunctiva is significantly scarred, then we look at the visual potential. If the visual potential is still good, it is worth considering glaucoma drainage devices. Although it is controversial, some authorities still recommend filtering surgery in combination with antimetabolites and angle surgery. If the conjunctiva is scarred, the visual potential is really poor, then I guess there's no room except for a cyclodestructive procedure. What about the timing of surgery? Is this an initial surgery or a redo surgery? If it's an initial surgery, then definitely filtering and angle surgeries are favored. If it's a redo surgery, then definitely valves are favored. So my take-home message would be, glaucoma after pediatric cataract surgery, it still presents a diagnostic dilemma, and multiple examinations would be needed to document progression. History taking is important. The cataract diagnosis and the cataract operation are important in the evaluation of the condition. Medical treatment has a role, and always remember angle surgeries and combining procedures with the angle surgeries. And to this I conclude my talk, and thank you very, very much. And may I invite Professor Khalil to take the lead, sir, please.
Thank you very much, dear Professor Nader. So this is the last talk, and actually it is a short talk I'd like to share with you. And as I rang an important bell of absolutely avoiding alpha agonists, eye drops in these children, this is another bill about the missed glaucoma, a case series of advanced late diagnosed juvenile glaucoma. So all names mentioned in the study are not factual. They are based on private practice and the glaucoma clinic at the Research Institute of Ophthalmology. In the glaucoma in the juvenile age groups between 6 and 20 years, newly diagnosed, accidentally discovered juvenile glaucoma cases. Various selected cases are reported here. This is my first patient, Hanadi. She was a 19-year-old girl who came with these pupils. One pupil, as you can see, in her right eye, and the left pupil is dilated. And if somebody later would like to ask me what about the consensual pupillary reflex, this is a flash, because I have been asked this question very much, and I realized the answer that it is a flash picture. So the pupil, the left pupil had no time to constrict. This child or this young girl actually simply didn't see with the left eye. She was given the diagnosis of glaucoma just a week before presentation and prescribed bilateral topical carbonic anhydrase and beta blocker drops. The visual acuity was 6.6 in the right eye and counting fingers 30 in the left eye with that pupil I have just described. The intraocular pressure with medication was 16 and 16 on bilateral medication. CD ratio was near 0.9 in the right eye and total optic atrophy in the left eye. Again, this is the picture, and this is her actual disc in the right eye. And this is her angle, and we clearly see goniodegenesis or trabeculodegenesis of her eye. When did this glaucoma start? So probably it started long ago, but it was just missed. This child or this young man, A. Nagy, long diagnosed with glaucoma with several surgical interventions in both eyes. Last were bilateral valve surgery. Right eye lost with no perception of light. Left eye advanced cupping with good control on full medications. This is his brother. And because his brother was discovered with glaucoma and suffered several surgical interferences, he sought ophthalmic consultation just because he is the brother of A. And third, his intraocular pressure was found with a 0.6 cupping. Now he was given all medications, and you see the long lashes of the prostaglandin result, and he was controlled, and later he went surgery, and his lashes shortened again with successful intervention. Again, this is a young friend of mine who presented with classic primary congenital glaucoma, and he was operated. Zizu, in the third year of routine follow-up of this young child, the father asked me to do glasses for his elder sister, who was 20-year-old, and she was always coming with Zizu to the office. And this is the sister Aya, a young friend who and when I examined Aya, who was just asked to do her glasses, the intraocular pressure in the right eye was 40 and the left 38 with advanced cupping on both eyes. The myopes. Abu Ahmed is another patient, and he is a moderate myope, was recently declined refractive correction because of form of frust keratoconus. So he came actually to manage his keratoconus, presented, and then his intraocular pressure again was up to 30 with a bilateral optic disc cupping. This is his visual field, and this is his OCT of the optic disc. So how long this 20/30 IOP has been ongoing in this eye? Again, another child. She presented at the age of 13, sorry for that, at the age of 13, again for glasses renewal, and has been making glasses for the past 6 years and had a recent marked reduction of right eye vision. Best corrected visual acuity was no perception of light in one eye and the left 612. Uncooperative child, the intraocular pressure was 34 and 28. So the CD ratio was 1, total cupping in the right eye, and 0.7 in the left eye. 6 years of doing glasses without having a glimpse on the optic nerve in this child. Both eyes were operated, IOP spikes after surgeries with eventual control at low teens. The right eye could see a partial 0.05 later on, and the left eye 0.9. And this is another intermediate case. Hamada first presented 11 years for glasses prescription. He has an excellent uncorrected visual acuity and an IOP in the high teens. Pachymetry was within normal, a little bit to the thick side, and some usually unusual cupping for this age. And this is his angle, goniodegenesis visible, and the cup disc ratio. This is his visual field, near normal or actually normal, and we have taken the OCT, although no normative database at that time, just for the record. So along successive follow-ups, his IOP rose up to 25 in the left eye, and he was operated actually after a very well-informed consent with the parents, and few months, his pressure lowered in the left eye, but the parents later on apparently had several opinions from other authorities, and the parents declined the right eye surgery based on a second opinion, and the boy was lost to follow-up 2 years later with an advancing 0.7 right cupping and a regressed 0.3 in the operated eye. So what is the relation between myopia and glaucoma in this age group? Is it cause and effect or an incidence? The operated. This is a young girl, 11 years, with history of congenital cataract surgery at the first year of life. Visual acuity was counting fingers, 3 meters in one eye and 0.5, 612 in the other eye. The IOP was 30 and 32 and advanced cupping on both sides. So Aisha had the affected glaucoma Professor Nader was just talking about shortly. And this Sayed is a 14-year-old child. He had left 2 trabeculectomies at the age of 4 and 5. And for his good luck, he was controlled actually with this left eye. So the visual acuity was in the right 0.8, and in the left eye, it was counting fingers. The IOP was 26/30 and 14/21 in the left eye. CD ratio was bilateral advanced cupping. So he was operated for glaucoma in one eye, and probably the other eye did not have glaucoma when he was first operated for the first eye, and it remained on progressing for years till he presented. So he was mostly a delayed diagnosis and management of infantile glaucoma. So glaucoma in this age group, all these are pictures of actual patients who presented at the teenage group. When we talk about glaucoma, we know birth, infancy, and we know late adult. Birth, infancy, we diagnose. This has been the subject of our webinar and episode today. Late adult, we measure intraocular pressure for the elderly. But older children, these are the least examined age group regards the IOP. So they are the healthy young. Why should I measure his intraocular pressure? Even when they present ophthalmologists for other reasons like glasses, allergy, or other, usually eye doctors are reluctant to measure eye pressure for this age group and often miss a glimpse to the optic disc, as we have seen in several of our cases. Topical steroids are prescribed commonly in this age group for allergic conditions. So the steroid-induced can happen. So in this young adult, it can be a developmental primary, either early developmental glaucoma, which is the congenital glaucoma, which was not diagnosed, or later onset, because we know that we have later onset developmental glaucoma. It can be secondary, whether steroid-induced common in this group, or aphakic following cataract surgery, or associated with other anomalies. So what we would like to raise the alarm, that children glaucoma is commonly missed glaucoma. It is commoner than what we think, to say the least. And with the more subspecialization, we all now are refractive surgeons, glaucoma surgeons, and then among refractive surgeons, subspecialization, and among retinal surgeons, subspecialization. Awareness has to be spread in all presumably unrelated ophthalmology subspecialties, like refractive surgery, strabismology, posterior segment, and others. That it has been a clinical routine actually for the author to measure the intraocular pressure for every living clinic attendant, regardless of his or her age, and regardless of the presence or absence of the disc cupping at least once in the juvenile age group. You don't have to measure on every visit for this juvenile age group, but at least once it will tell you if this child can have this dull or grim possibility. Thank you very much for keeping you this late.